An aniridia IOL for optimal correction of congenital and traumatic aniridia was developed from 1991 on by Rainer Sundmacher as ophthalmic surgeon and Olaf Morcher as IOL designer. The large, unflexible IOL consists of a 5 mm central optics embedded in a 10 mm black PMMA diaphragm. The haptics diameter is 12.5 mm. The lens can only be implanted into aphakic eyes. The geometry of the standard lens was developed step by step and fits all eyes which are not extremely large or small. It has been in use since 1993. Primary indication was congenital aniridia with lack of iris, hypoplasia of macular and optic nerve, nystagmus, early progressing cataract, and often glaucoma and limbal stem cell deficiency. This young patient exhibited all signs except for still missing glaucoma and limbal stem cell deficiency. First surgical step is a 180 degrees partial incision of the peripheral cornea. It follows via a small corneal opening, capsulorhexis, phaco, and cleaning of the capsular bag. The rhexis line is visible between the arrows. A central fibroplasia is primarily left. After injection of viscoelastic material, the 180 degrees incision is completed by scissors. Then the aniridia IOL is implanted. The advantages of the corneal incision for anterior segment stability and easy control of all surgical steps are quite evident. Proper position of the lens is then checked and eventually corrected with an angulated cannula. The viscoelastic is removed and a single running corneal suture with 10-0 nylon is placed. as nystagmus makes post-op laser treatment of the fibroplasia very difficult, it should be removed during this operation, either by posterior rhexis before IOL implantation or, as preferred here, via a separate, safe and easy-pass planar approach after completion of the lens implantation. Neuronal hypoplasia, amblyopia and nystagmus of these eyes let us primarily doubt that optical improvement does really pay out for the patient in worthwhile functional improvement. This, however, is indeed the case, and to much more extent than we would ever had anticipated. Mostly, vision improved considerably together with some reduction of nystagmus. No eye deteriorated. The operation you have just seen was performed in this young lady who tells the interviewer that before surgery she had to use low vision aids for reading with no chance of seeing much more than shadows when facing light, and that she now can use normal reading glasses and can easily face light. She was so impressed by this never-before experienced quality of vision that she insisted on having operated her second eye as soon as possible. Also very rewarding are the functional results in traumatic aniridia. They are, of course, limited by functionally relevant traumatic damage of these eyes, above all macular damage, retinal damage, and glaucoma. Also, these eyes present additional and sometimes difficult surgical problems because they are generally aphakic with no capsular ring left which could support an IOL. The large aniridia IOL has to be fixed transsclerally by sutures. Here, the scleral flaps are already prepared and anchoring sutures pre-placed. Then, the perforating peripheral corneal incision is performed. The anterior vitreous is removed if that had not already completely been done in prior operations. The most important special surgical step, however, is to place a long, straight, supporting needle through the globe slightly behind the sulcus region from 4 to 8 o'clock as indicated by the errors which you saw previously. Then the long transfixing needles with 10-0 proline sutures are passed through the sulcus and the scleral basis of the flaps. The haptics of the aniridia lens are firmly tied to the proline traction sutures. Letting the surgeon struggle a while with these sutures, it can be seen that even such a soft eye without vitreous does not collapse and is reasonably stable without a disturbing flearing. This is one of the advantages of the corneal incision in these cases. The IOL is partially implanted and the first loop fixed in the sulcus by a provisional knot. Then the large diaphragm is advanced to lie on the supporting needle, which guarantees that it stays perfectly horizontal and in the right plane during the somewhat difficult positioning and fixation of the loops. Without this needle support, the IL would decline posteriorly on the pars plana at 6 o'clock without a chance to reposition it correctly. Only after correct positioning of both loops, the traction sutures may ultimately be fixed. The supporting needle arrow is left in place until the corneal incision is provisionally closed by temporary sutures and the eye has thus gained near normal stability. Then the needle is no longer necessary and is withdrawn. Surgery is finished with a single running corneal suture and closure of the scleral flaps and the conjunctiva. The IOL is perfectly centered in the sulcus behind the remnants of the iris base. Major concern has been an increasing incidence of glaucoma after surgery, which, however, may also be observed with any other type of surgery in such eyes. Most glaucoma problems were managed successfully. For safety reasons, however, we advise do not implant the lens into eyes with congenital aniridia and established glaucoma, not even if the glaucoma seems to be well controlled pre-op. And do not implant the lens into eyes with traumatic aniridia and glaucoma unless the glaucoma has been very well controlled either by surgery or by eye drop medication pre-op. If perforating keratoplasty is also needed, a two-step surgery is recommended with implantation of the lens from a separate incision either some months prior to or after Kipei. Detailed technical information may be obtained from Morcher Company, Stuttgart, Germany. The authors of this film have no financial interest. They regard the aniridia IOL as a new major advantage for patients with congenital and traumatic aniridia and recommend its use by the experienced ophthalmic surgeon.